Cool. Well, I guess we can just dive right into this then. Dan, Taylor, thanks for coming on today.
Thanks for having me. It's exciting to be able to chat, catch up a
Yeah, for
little.
sure. It's been a little while. I guess it hasn't been that long because we saw each other just, I guess it has been. When was that? Like maybe May?
Uh, Maybe. I
Yeah,
don't know,
May or
man.
June.
Time
Yeah.
time is weird and
Yeah, it feels like it's been a long time, but
yeah,
yeah, I appreciate you coming on. So for those of you who don't know Dan, Dan is a paramedic, and we'll get into a little more of his background shortly, but he's had a pretty cool career in that he's done a lot of work as a medic in, um, I guess you could say like atypical environments.
yeah.
So that's kind of what we're going to talk about a little bit today. So maybe to start off with, Dan, do you want to talk about like how you got into EMS and working as a medic, and then we can out from the normal 911 operation stuff.
Yeah. I mean, kind of going way back, like I did some volunteer stuff in high school with like wilderness search and rescue, thought that was kind of interesting. Went to undergrad, got involved with an ambulance corps, became an EMT, uh, figured out that kind of working on the ambulance was a lot of fun and started thinking about it as a career. Um, Became a medic in New York, worked full time on the ambulance for a number of years, doing 911 and interfacility in both urban, suburban, and rural areas, which was pretty cool. I mean, I got a variety of patients, different transport times. And then through that, some of the agencies I worked for would do like special event medicine for like triathlons, big concerts, stuff like that. So that was kind of my first exposure to like working as a pre-hospital provider away from the ambulance in like a really formal way. And that kind of opened my eyes in a lot, and especially working alongside some really pre-hospital forward physicians in those like special event environments. So that kind of got me interested and looking for other things we could do. I became a professional ski patroller, and that was a lot of fun. I got to ski, and then I also got to start doing like medicine and like wilderness medicine and working out of a backpack and really thinking about how the environment creates additional challenges and how we're like resource limited and really trying to maintain a good quality of patient care in what was at times a challenging environment. And then that got me kind of into the wilderness medicine world. And then so I started following like Wilderness Medical Society and attending conferences and additional classes kind of within that bubble as I was able. And then started looking for other things that I could do to expand my experience, to encounter new problems. That brought me to the film world, the TV and film world, and I was able to work as a set medic. First well, in a couple of kind of wilderness environments. I volunteered with Team Rubicon and I deployed to Greece and I worked in a refugee camp there. And that was my first exposure to like true humanitarian medicine and the problems, the challenges, the complexity of dealing with not only those populations, but then a foreign healthcare system, um, seeing new medications, trying to work with local healthcare providers, being a patient advocate through an interpreter, like all of these things that were connected in some ways to stuff that I've done before, but didn't necessarily in some cases have formal training in. And then basically from Greece, I kind of kept saying yes to things. I was able to start doing some teaching in like the wilderness and austere medicine world. That got me more contacts and more experience, and I was able to learn more through that. Eventually worked offshore in the oil and gas and commercial fishing industry as a medic in the Gulf of Mexico, in Alaska. Um, Worked with a small NGO and deployed with them a few times in Iraq, Sierra Leone, Mexico, Ukraine. Um, and yeah, kind of kept attending training, looking for new opportunities. and then growing my network. And through that, I was able to learn different skills, step into different roles, and just kind of try to have fun and make the world just a little bit better along the way.
Yeah, that's awesome. Yeah, I want to try and remember to like come back to that idea of as you do more of this type of stuff, just that network you create and you build for yourself really opens
Yeah,
up a lot of possibilities. Because I know that was something that I struggled with early on in like wanting to do like overseas work, is that you just don't know where to go. And then
yeah,
eventually you wake up one day and like your inbox is just full of opportunities. You're like, oh shit, now I have to decide like how to prioritize where I want to go.
yeah.
Uh, but yeah, that's
And that
awesome.
that network also makes it easier when you start getting those opportunities and you're trying to like vet people or organizations uh or like you're being asked to go to a country you've never been to. But if you can just text somebody and be like, hey Krista, you've worked here for a year, what can you tell me
Totally.
about X country, right? And that, yeah, that makes the deployment process and even the work on the ground just like so much smoother and safer and more comfortable in a lot of ways.
Yeah, for sure. And then well, before we talk about what you're doing right now, what were you doing up until just a few weeks ago?
Yeah, so basically the last year, so I have a pretty strong history working in Ukraine. I spent most of 2019 there, most of 2022 after the full-scale invasion, some of 23, and then from April of 2024 until yeah, just a few weeks ago, I was working in Ukraine. So most kind of the last like two, three roles I had were all clinical. The last one I was working for a defense contractor, a US company. I was their medic, and they have some foreign personnel in country doing kind of like an advise, assist, and accompany a sort of mission. So I was their medic. And then immediately before that, I was working very close to the front lines, doing patient care, a mix of role two, which is more like level two trauma center, like similar equivalency. And then working in medevac, which technically like it's a medical evacuation. And maybe we can talk about it a little bit more, but it was a little bit closer to critical care transport because we're taking patients that are pretty sick. They've just come out of the operating theater, and now we need to move them to a higher level of care. And that was one of the places where I really started thinking about this conversation. And then I also spent time working at a stabilization point, which is it's a fixed facility. But it's very small. It can accommodate one critical patient at a time, and then a couple of like greens and yellows. They're typically staffed. The one I was in and similar size are typically staffed by four people. You'll have a physician or a provider. I filled in that role as an advanced practice paramedic, combat medic, and then usually two Ukrainian soldiers who have like some degree of basic trauma TCCC training, but they're not considered healthcare providers. And so that facility was underground. It was fairly close to the front because we had to be, because we were the first people to receive some of these casualties. So we needed to be able to be close enough to make a difference in some of those cases. And we would do temporary stabilization and then very quickly evacuate them to the next level of care, which would be kind of the more of a proper role one, which is like a maybe level three trauma center, and then a role two is more like a level two trauma center.
Right on. And I think I
Yeah,
remember not too long ago, Quorum had a podcast out talking with someone who's done a lot of work over in Ukraine, and they kind of talked through like disambiguating all of these terms because there's like,
yeah,
yeah, it varies a little bit on the context. But if anyone is interested in that, I'll see if I can track that down and put a link in.
yeah. The role terminology is U.S. military and NATO.
Mhm.
Um, I've never served in the military. I've worked for the U.S. military and I've done training for other militaries. So I've learned a lot of this stuff as I've gone, but yeah, so just for the terminology, that's and CoROM's a great resource for not only the
For sure.
podcast, but for training in general.
Yeah. And you've been on the Quorum podcast before, if I remember right. Yeah.
Yes. Yeah. Yeah. I
Yeah.
think 2 years ago, I talked about kind of like the first, I talked about most of the stuff I did in Ukraine in 2022 in a bit more detail.
Right on. Awesome. And then what about now? Because you recently had a big transition, I guess you could say. So where are you at these days?
Yeah. So now I'm in North Carolina. I just moved back to the US and took a full-time job. I work for a private organization that does disaster response with a focus on the Caribbean, Central America, and the South Pacific. And I'm part of our forward response team. So we respond very quickly when we're invited. So my role now is a mix of medicine, rescue, logistics, communications, a little security, some water sanitation and hygiene. But I'm kind of a disaster generalist with a focus on natural disasters.
Awesome. Yeah, and like that breadth of experience is kind of why I thought it'd be good for us to chat. So a little bit of a disclaimer here is that this is actually Dan's idea. Dan has done a lot of like, I guess you could say like public facing stuff. He's like taught at
Yeah,
conferences and like been on a number of podcasts, I think. There's been more than one, correct? Yeah.
yeah. There's been a couple. Yeah, I'm
Yeah.
not very good at self promotion, but I've done a couple.
But he had asked me this last year to if I'd be interested in presenting with him at a conference. So we kind of like put this concept together, but it never quite panned out. But I thought it might be a good idea to just chat about these things here. So the initial concept was like discussing like how you can use paramedics and specifically like paramedics who are trained in like the critical care transport side of things, like how you
Yeah,
can use them as an asset or a force multiplier in more austere settings, like whether that's humanitarian response or like embedding with the military for like conflict response or things like that. Um, so yeah, that's kind of why we decided to have a chat today since we missed the opportunity on that conference.
yeah. Yeah, I mean,
Yeah.
and you're a great example as well, right? From Haiti to Ukraine to Gaza to Mexico. I mean, you have this incredibly high level of training and experience, and you do like very traditional critical care stuff, right? And then you also go to these sometimes horrific places and employ those skills. And that was yeah, that was part of what kind of made me think about it. And it was also I was looking at some of the patients and some of the equipment that I was encountering in the role two in the medevac and thinking, it would be really great if I had an adult like Ryan here to be able to, help and reassure me and because like you've legitimately done a lot more critical care than I have. Like I've passed the exam. Like I know some stuff. I can look things up. I know where resources are, but that doesn't account or that doesn't fully address the lack of like direct experience and real high quality mentorship. So I think like
Yeah.
someone with your background is an incredible resource in these types of environments.
Yeah, and I think that's one thing that we'll probably like touch on later is that you're never gonna there's no one person who like has the breadth of experience to like
Yeah,
make or break a response like in this general scene. So like team composition is like a huge component of it. So if you have
yeah,
folks with like, like different types of experience in this like general like paramedic or paramedicine or critical care transport realm, and you could bring them together, I think there's a lot of value there. So like someone in my exam, like for me, for example, like I have a lot of experience in like, like very acute critical care transport, but maybe less so in like the operation side of like working in specific environments. So yeah, it's like I think that was why we decided it would be a good idea to collaborate on this a little bit.
yeah,
Um,
absolutely.
so just maybe to set the stage, what are some examples? I know you've mentioned some of the work that you've done, but just in general, like what might be like a good use case for using a critical care transport clinician or a paramedic. I guess these CCT folks could be like nurses as well, but someone who has that
Yep.
experience, like doing the critical care transport side of things, like what would be a like a use case for them in one of these contexts?
Yeah, so I think there's two kind of general cases that I think can be really powerful. So if you have a gap between surgery and the kind of next highest level of care, if there is no indigenous critical care transport, um, there's a real possibility that surgeons could do amazing work and then the patient dies during that transport because the vent settings are wrong, because the patient is starting to come up from RSI, right? Because there's unrecognized bleeding. Like there's so many things that could go wrong that would negatively alter that patient's outcome. But because it's one thing, like even in the US, emergency medicine as a physician discipline is relatively young. That is even more so true in other countries. And so then the idea of having critical care transport ability that is not a physician or an anesthetist is pretty rare in some places, and doesn't even exist in some places. I mean, there's some places where your regular 911 ambulance person is closer to what we would consider like an EMT or an advanced EMT, right? um, so then we take somebody right out of the OR for whether it's operational or patient volume, for whatever reason they're not able to convalesce for an extended period, a couple feet from that operating theater. They need to quickly move from there to somewhere else. That critical care provider can do a really incredible job dealing with all of those conditions and making sure that the patient does as well as possible, moving from basically point A to point B. And then I think the caveat with that is that pre-hospital people tend to be pretty flexible with equipment, protocols, medications. I mean, even in the US, like, I've dealt with shortages on benzos or, saline, right? We're used to having to make some adjustments. And so now if you take that critical care person and you put them in this, maybe it's a foreign ambulance, different meds, whatever, as long as you give that person a little bit of time, especially with medications, if you give that person a little bit of time to read up on the meds that they now have access to play with the ventilator, to play with the pumps, right, to get familiar with that different equipment, they have the plasticity to be able to say, yeah, event is event. I'll look at the manual, I'll work through the modes, like I'll figure out what is proprietary and what I know the concepts of. Um, and then they'll be able to do a great job with that patient. Whereas I think other healthcare providers or physicians may be much more uncomfortable doing that. Um, and maybe they still do it. I don't know, like I don't have any evidence to support if there would actually be a difference in outcome, but I think everybody is going to be a little bit more comfortable if somebody who is already more comfortable working in that environment is able to do it. So that's kind of like the first kind of general case. And then the second one is if we're dealing with things like significant pain management, procedural sedation in a somewhat low or lower resource environment, where if we're going to RSI someone or if we're going to do procedural sedation, the quality of care needs to be the same, whether we're talking about an operating theater in sub-Saharan Africa or Ukraine or the US, right? We might have to make changes and maybe we use a medication that has a slightly worse side effect profile, right? That might be the only thing we have access to, but we're still not going to let that patient desat, right? We're still going to pre-oxygenate. We're going to do all these things that we are trained to do to ensure that those patients have the best chance possible. And so, if we already know how to do RSI sedation, if we're already comfortable giving fentanyl or whatever meds we're talking about, we can take that from a moving vehicle and now move that to a patient care room in a facility where maybe the alternative, if we're not there pushing those meds, is that the patient goes through an incredibly painful procedure without pain meds, or with Tylenol, oral or IV Tylenol as the only thing for like wound debridement. And I've seen this firsthand. But if we have that person that is comfortable with these meds, that is comfortable monitoring that patient, and is comfortable kind of like setting themselves up in a new space, now you can safely do procedural sedation or RSI or whatever it might be in that environment. And we have made things a little bit better. Um, so yeah, so I think that's kind of a way to transition those skills over to that other environment. And
Mm.
especially if we're talking about the in-hospital, we're taking responsibility for a small part of the patient care, right? I'm not telling anybody to become a surgeon unless you want to go to medical school and do all that. Um, but if you have a provider doing a procedure, you can focus on the pain management, the sedation, the airway, right? You don't have to worry about the leg that's being amputated, or is, they're dealing with the X fix or wound change or whatever, dressing change. You can just focus on the pain and the airway. Like we're cool with that because that's something that we do every day, multiple times a day sometimes, right? Yeah, so there you go. So those are two kind of general cases that I think make a lot of sense for us.
Totally. Yeah, and that first one you mentioned about just like doing the critical care role or the critical care transport role specifically, that was something like we realized very quickly in Ukraine. There was like a pretty robust like 911 EMS system, like even before the war, but
Yeah.
once there was like this influx of casualties that needed to get from point A to point B, there was, yeah, there was kind of a gap there. Fortunately now, um, the war has afforded like the medical system of Ukraine like the opportunity to like fill that gap. So like now they don't, there are some niche cases, but for the most part, like Ukrainian providers can now do that thing that we were doing initially early on. It's more an issue of just being like generally under-resourced
Yeah,
nowadays.
I mean, I was in the Pokrovsk area, and we were still, I mean, as of like February through May, basically of 2025, like there were some NGOs that are providing it. There were some Ukrainian medics that had been trained up to a higher level, but it still there was this challenge of like some of the military units had great combat medics that maybe they could do like push dose fentanyl, push dose ketamine, but they're stationed at a roll one, and a patient has just come out of the OR from a damage control surgery. They're on a vent, they're on a propofol drip. They were also using mannitol in some cases, and they have atracurium on board, as that was their most common paralytic that I saw. Um, that's not part of TCCC, right?
For
That's not
sure.
part of normal combat medicine. Like if you look at the joint trauma system, there is the en route care guidelines,
Mhm.
but that's not TCCC. That's not what most military medics are learning. So we still had this gap. And now there were a lot of patients. I mean, some of your simple ortho patients, people that had rapidly stopped hemorrhage, and then got a transfusion, like those folks absolutely were well within the wheelhouse for the combat medics, and they did a great job taking those, and making the patients comfortable, and doing everything that they could. But yeah, it was the sicker kind of like post-surgical cases that I saw the gap still.
Yeah, for sure. Yeah, and I wonder, I guess I'm not totally sure like how much of that is like that there aren't folks with the training versus just not enough of them. Because there are some
Yeah.
like ambulance services now that are doing like critical care transport with physicians who have worked pre-hospitally. I just don't think
Yep.
there's a lot of them. So there still is definitely a
Yeah.
need for folks with that skill set in Ukraine,
Yeah.
even today.
Yeah.
Yeah.
And it's people also, I mean, people that haven't been to Ukraine also underestimate like just how big of a country it is.
Yeah,
So if
for
you
sure.
need to cover that entire front of the war, and space out some critical care capabilities between ambulances, and we have these buses that do transports. Um, that's just like a logistics problem,
Yeah.
right?
And you can't fly.
Oh yeah, yeah. Flying is bad. Flying is a quick way to have a hard landing.
Yeah.
Uh, yeah, and to the Ukrainians' credit, like there have been a handful of very dramatic and daring like helicopter rescue missions where they did, and there's some that came out of Mariupol early in the war where they evacuated via helicopter. But yeah, it's not a viable option. And then, especially with the increasing number of drones, like the long range stuff, where in one night you have 500 or 800 large, like car sized drones over the country, you can't even say, oh, well, we'll just drive them to Kyiv and then, put them on a fixed wing and then take them out, right?
Mhm.
It's just unfortunately not really an option right now.
Yeah, for sure. And then you mentioned the case already of like a critical care transport person helping with like an RSI or procedural sedation.
Yeah.
Um, what are some other like clinical situations, like not necessarily like, taking over an entire case, like taking over like the care of a patient from start to finish? What are some other like ways that these folks could maybe insert themselves to be clinically useful?
Yeah, and so kind of like a lower stress one, and we both did this in Mexico. If you're dealing with sort of a more primary care type environment, what like the military would call sick call, um, or like urgent care type cases in a refugee health, like that sort of setting, the pre-hospital providers, I mean, we're great history takers, we're good at vital signs, we're good at recognizing sick versus not sick, right? So if we're looking at a line of 30 patients that are waiting to be seen, I would take that pre-hospital provider, and if they get a bad feeling about somebody, we're going to pull that patient out of line and then try to figure out what gave the person that bad feeling, right? I mean, sometimes that's how we're catching the patients that are borderline septic, or severe mental illness, or electrolyte issue, septicemia. Some of these things that can kind of be slower onset, but that we've encountered in our various settings before. Um, and in some of these populations, you have folks that they're tough, like they've had hard lives. They are tough and they are stubborn, and they're not going to step out of line because that would be rude, even if they are having crushing chest pain that radiates down their arm, and right, like all of these things are like, well, no, I'll be seen when I'm seen, but that pre-hospital provider can do that. So in that context, we can do triage, much like a hospital. We can do the history taking, the vitals. Um, we may be really useful, especially if there's a language barrier, as kind of the first layer of sorting. So if you pair the paramedic, whoever it is, with an interpreter, and so we're collecting this information, we're kind of creating some order within the chaos that can often work in these places. The physical exam sometimes can be time consuming. And so if we have somebody maybe with multiple soft tissue problems from some places you have issues with bugs, with hygiene, this kind of stuff, you can have a pre-hospital provider that does a really good physical exam in appropriate setting for privacy. And then they can start flagging things and say, hey, this patient has what looks like a pretty decent sized abscess. We're going to make note of that. But otherwise, their vitals are great. They don't have a temp. We think it might be kind of an isolated thing. Or, we're seeing, this is severe phlebitis, and I am actually seeing a fever on this patient. So again, we've combined doing a good, really basic physical with that history taking and the vitals. And now we are maybe making a difference in that patient's outcome. Because in a lot of these settings, the physician level provider, uh, there's often not enough of them. And so if we can do a really good job and act not only as a physician extender, but really to help uh, prioritize and truly triage these folks, that can make things a little bit easier. We're used to stocking our own bags, right, and restocking. So if you take a pre-hospital provider and you say, hey, you've got multiple boxes of donated medications, and we have a tent, a cabin, whatever that's going to be our pharmacy, like we've gone through boxes and restocked things, and we know that you're supposed to organize things in certain ways. Like, so it's maybe not something we were formally trained to do in a classroom, but we've all restocked ambulances, all this stuff. And so it's this kind of other thing that, yeah, we can do. Um, I mean, anybody that's also worked for maybe a more budget ambulance service has probably had to repair equipment before.
Right.
So maybe you're good at troubleshooting, the Life Pack 12 or whatever stuff. So maybe that's kind of another thing.
Yeah. Now, those are all good examples. And in my experience, I don't know if yours is the same, but I feel like when I first started doing this kind of stuff, the like filling gaps in like a provider's workflow like always seemed kind of intimidating. Like
Yeah,
doing the history when I like didn't know what to do about the diagnosis part, or like doing the exam when I like wasn't sure about the treatment part. That initially, when I was like first getting into this kind of work, was like a challenge. Because it, yeah, it feels like very strange, like you're like, getting in someone's way or like wasting time. Um,
yeah.
I think there's definitely a way to do it that facilitates a workflow rather than impeding it.
Yeah. Well, and you already mentioned team dynamics and team composition, right? And I think this is where having the right type of physician provider uh, in the environment where you guys can sync up beforehand, and the pre-hospital, the pre-hospital provider, the EMT paramedic, can say, "Hey, these are the things I'm comfortable with. I'm thinking I might be able to fill in and help in this way." And then the physician can say, yes, that's going to be helpful, or actually, I think it's going to be more helpful if you do XYZ. I forgot to mention like a 12 lead, right? We're not only always talking trauma, sometimes we're talking medical patients. So,
Yeah.
if you have somebody like in some of these settings, we do have 12 leads. They have become smaller, less expensive, and you can get 12 leads that are standalone from a cardiac monitor, right? So something like flagging a patient that has cardiac risk factors and maybe has ambiguous symptoms, and then the paramedic throws them on the 12 lead and then brings them over to the provider, like that saved everybody a little bit of time.
For
Um,
sure.
so yeah, uh, I think it's about kind of knowing yourself, knowing your skills, and then having a team where you guys can have this kind of open conversation. And I've had physicians say like, "Hey, I'm really uncomfortable doing whatever," because sometimes you get a physician that has a specialty, but it's been years since they did, family medicine, women's health, primary care, right? And they say, "Hey, look, I'm great at urology, but I haven't seen a peds patient in 20 years." All right,
Hmm.
cool, man. Like I work on a pediatric critical care transport, right? I see kids
Yeah,
all the time in some cases, right? So you have people that can identify their strengths and weaknesses. Um, and yeah, it comes down to having that team and the dialogue.
for sure. Yeah, it's a good point about the providers themselves being in a setting that they're not used to, like in a disaster situation. Like, I mean, remember here during COVID, we had like family med docs like working in like makeshift ICUs, taking care of,
Yeah.
a whole suite of patients on transport ventilators, basically. Um, so yeah, I think that's a good point. Like where I'm working now, um, we have a lot of like local physicians that we work with. They are like the primary, you know, the primary ones like providing treatment in the emergency room. But most of them aren't emergency medicine doctors. Like before the war, they were pediatricians or family med docs or, like always worked outpatient. So that's definitely worth keeping in mind. And then
In
what
some of
about,
these places, we also just have like regular, especially if you're in like a refugee camp type setting. Sometimes people just have like regular run of the mill emergencies, hypoglycemia, seizure disorders, things like that. And that's exactly the patient that you want a paramedic to deal with because you're out of hospital. They're having a sudden onset medical emergency. Cool. Like we can do that all day.
for
So,
sure.
and it's going to be usually outside of like a conflict, it's going to be a small number of like true emergencies.
Hmm.
But when things go sideways like that, you want somebody who's comfortable dealing with it. So
Yeah. Um, what about situations in which like you might have to like do things different than you normally would or like deviate from like pre-existing clinical expectations?
yeah. So this is one of the places where there are some documents that can absolutely help us. 'Cause I think like I said in the beginning, we're not trying to do cowboy medicine. We're trying to really maintain an appropriate standard of care for our patients. So things might look a little bit different, but the fundamentals should be the same. So if we look at the joint trauma system, there are clinical practice guidelines for prolonged field care, for critical care transport. These are publicly available documents, and granted, they are written for the US and kind of NATO audiences. So sometimes they might talk about specific equipment that's not affordable, or there's an assumption that a helicopter is going to be there in 30 minutes and then a C5 is going to be there in an hour. Um, but there is a lot of good content in there because fundamentally they are considering a more austere environment. So from an equipment standpoint, like uh capnography is going to be an incredible tool for a lot of our airway stuff. So if we don't have a proper, a life pack 15, we don't have a Zoll monitor with the capnography built in. There's a device called an EMA. That's this little thing. It's a little bit bigger than a pulse ox. It goes between your airway device and your BVM or your vent, and it gives you, depending on the generation, because there's three of them now, it will give you definitely a end-tidal CO2 number and a respiratory rate. That's the first generation. The second generation will give you a waveform plus those two, and then the third generation gives you Bluetooth connectivity, so you can wirelessly connect to that device and monitor remotely. But so that's a nice little tool where we are still using capnography to confirm an intubation. It's just going to look a little bit different, and we're going to use like I know some people still carry colorimetric. I don't want that. I want real-time continuous monitoring. I've purchased my own Emma. I got a good deal on eBay. It's something that travels with me. But I think if we are talking about doing professional critical care or critical care adjacent patient care in these environments, we can bring a tool like an Emma, and we can use that, right? Because yeah, I mean, everybody knows how important capnography is in this context. Um, Again, thinking about smaller devices, we might use a fingertip pulse oximeter, much more than something connected to a larger monitor or event. And that might be our primary pulse ox. So, with the understanding that in some cases, you may have a little bit of a delay between central circulation and peripheral. That if you have a patient in shock, you're going to have to deal with decreased perfusion in the fingers. So there are limitations, but now we can, with some smaller devices, we can still think about appropriately measuring and monitoring our patients over time. Um, we might look at using like low flow oxygen if our ventilator will accept that, because maybe we only have like a portable, like a home type oxygen concentrator. So now we're running a low flow source, like up to 6 liters into our vent. So we're still providing uh, oxygen. We are just not providing it from a big tank because that's not available, or maybe one tank is available, but we're not going to be able to refill it very easily. So we need to use that pretty sparingly. Some of the equipment, like some of the vents, some of the monitors might be a little bit older than what we're used to at work. And so then it's kind of just a matter of pulling out the manual. Um, I mentioned medications before. We may have meds that maybe we are familiar with the class of medication. Like it is a benzo, it's a uh, uh, depolarizing paralytic, but the specific drug that we now have in our ampule uh, is unfamiliar to us. All right, let's spend a little time, with PubMed or with another resource. If our local healthcare providers are familiar with that, we can figure out kind of the pros and cons of using that. Um, So we can look at our medications and try to figure out what adjustments we need to make. Maybe there are additional side effects. And so we're thinking maybe this is something that produces more nausea or more hypersalivation, right? And so we're going to pair it with another medication that we wouldn't normally have to try to balance that. Um, I mean, pain management is something that can be difficult. And so maybe rather than just jumping first to, to a stronger dose of fentanyl, because maybe we have a very limited supply of that, maybe we are going to try like PO, ibuprofen, and acetaminophen and see if we can take the patient's, pain down a little bit with that. Or maybe it's going to be IV Tylenol. Um, so maybe we're going to try other strategies to manage the pain, whereas in a more normal environment we could say, oh, we'll just give enough fentanyl to make them comfortable, and then we'll be at the hospital in 20 minutes, right? Um, so those are, I think, some of the cases. And again, going back to these clinical practice guidelines, especially the prolonged field care and the prolonged casualty care guidelines have these minimum better best recommendations for whether it's airway management, pain management, wound care, and within these guidelines there's different procedures. And so they'll say, the minimum for a wound dressing is X, the better is Y, and then the best is Z. And so if you are packing or if you are at a local market or a store buying stuff, you can say, hey, we have a limited number of the best. So we're going to save that for some specific patient populations. But we have a nearly infinite supply of the minimum. Fantastic. Let's use that, in abundance and as appropriate. But we don't have to make that improvisation and that judgment call in the moment. We can look at these guidelines and make good decisions in advance, understanding that those guidelines are written by both physicians and people with significant field experience, and in some cases, researchers as well, so that we are combining our understanding of the operational environment, the equipment that we have available, and then these external resources to help us modify our care in really logical and sustainable ways.
Yeah, that's awesome. So we talked a bit about like how it might look in a clinical setting. So I think that's fairly clear. But like, how does one, like, if somebody's interested in this, somebody's listening and be like, this sounds awesome. Like, how do I do that? Because you and I both mentioned that like it's not as easy as just like signing up and going. Like, how does the process work for like finding these opportunities and like getting into this sort of thing?
Yeah. So, so like one, so if, like some folks, if folks are already in the military, they may have already gotten some of the medical training, especially on like the special operations side, that sets them up really well to work in these environments. Um, for other folks, like we can develop the knowledge and the skills incrementally. So I mentioned part of my backstory was special event medicine. So if you have access to that in your area, if you can work, major sporting events, NASCAR, Burning Man, EDC, the big electronic music festival, if you can work some of these big events, a lot of that patient care is going to be treat and release on site. You're going to be working alongside physicians and NPs and PAs. And that may be kind of one avenue to start getting experience and potentially networking. And it may also, depending on your employer, they may be willing to send you to some additional training. I mean, if you have a part-time job at an urgent care, like that's probably pretty useful, especially if you have a team there that will let you learn more, that will, show you other procedures. I mean, even just basic wound care, an incision and drainage for an abscess, placing a Foley. Like these are things that we don't normally do in an ambulance setting, but are super useful in either extended care, prolonged care, or some of these refugee health settings. So if you're already working in that urgent care, if you work in an emergency department, tell, if you have a provider that you're comfortable with, tell them like, hey, I really want to go volunteer on these types of missions. Can I learn more in the ER? And of course, I mean, there's liability, like there's all these other considerations, but um, that may be a really good step forward. Getting experience is always going to be useful, especially if it's experience with a mentor. If you're able to join one of the disaster medical assistance teams, one of the urban search and rescue USAR teams, those are all going to be well-established programs. There's a clear barrier for entry. There's ongoing training. There are experienced personnel. It's part of a federal system. Um, at least as long as those programs exist. And so that may be a really good way to go from sort of being a street or a more traditional transport provider to now working in a non-transport or a partial transport environment with personnel that have experience doing the stuff. Like the USAR teams, I'm most familiar with them not as a domestic resource, but as an international thing. I mean, there are several USAR teams that used to deploy to places like Turkey after they have a massive earthquake, or Haiti. Um, and the capability that those teams are able to bring is really, really remarkable, not only on the medical side, but bringing in, civil engineers and other types of engineers and communications and all this other stuff. So DMAT and USAR, I think, would be really, really useful. Look at the Wilderness Medical Society. So they're a professional organization for wilderness medicine. They have some clinical practice guidelines that are useful. They also do conferences. They do online classes and lectures. Um, so that's kind of another organization that has multiple purposes. Um, Social media can certainly be useful. There's a lot of NGOs and other organizations that will, post on Instagram, and you can, look for the groups that are out there. Um, you know, do your homework, do your due diligence. You know, the organizations that are doing the most sustainable, and in some cases, kind of less exciting stuff will probably be safer. Um, the folks that are doing the really spicy and at times very interesting stuff will probably be more risky, and you as an individual will have to take on more responsibility for your well-being and safety, and not only during the mission but also after the fact. So kind of think about, small versus big organizations when you start looking at folks. But yeah, I mean, start small, like look towards the wilderness medicine world. Um, if you already have a big skill in mountain biking, skiing, climbing, there are probably opportunities, whether it's through like National Ski Patrol, or through other groups, to use that skill in addition to your medicine to support expeditions. I mean, so a lot of that's going to be volunteer, but that gets you thinking about, I have an 80-liter backpack. I need to be able to provide this level of patient care. I also need to carry this amount of water, food, my own sleeping bag, right? So now you are thinking about mission planning and logistics, and you're also now thinking about, well, how do we get this patient out if we have a problem? So now you're thinking about the different ways we can do that, and the manpower and the evacuation resources, right? Um, so yeah, but you would, to do a lot of the expedition stuff, you need the underlying outdoor skills, whether it be mountaineering or mountain biking, whatever, right? To be able to function in that environment. And then you're going to add medicine onto that. Um, so yeah, I mean, kind of follow your interests, and if you already know somebody in your community, maybe it's, a paramedic who works part-time, at your ambulance service, or maybe there's a physician in your area who's part of a wilderness medicine fellowship. Like, reach out to them and see if they have a lead. Ultra marathons are another place where it can be an easy step into getting some experience, because most ultra marathons will have some degree of medical support. Maybe it's BLS, maybe it's more sophisticated, but you'll do a lot of foot care. And honestly, that's pretty useful to learn how to do, because when people's feet are in bad shape, like the rest of them follows pretty quickly. So yeah, and then that also gets you thinking about, limited resources and evacuation and all that kind of stuff.
Yeah. And then one other thing worth mentioning is there are many, many, many like NGOs or nonprofits that do like international missions. So they'll like put a team together to go to whatever country or whatever part of the country, um, to go do medical support just in general or for a specific thing. Um, so that's kind of how like I kind of like edged my way into this space, was just going online and like picking a place I wanted to go and seeing like who was working there and
Yeah,
just sending blind emails and seeing what took. Um,
absolutely.
yeah. What about classes? Like, are there any like specific courses you could take?
Yeah, 100%. So I mentioned the Wilderness Medical Society already. They do two conferences every year. Those, they'll have a variety of topics focused on care outside of the hospital, from from like mountain biking injuries that are an hour from a level one, all the way to, diving expeditions and things like that. And they'll have pre-conference, workshops that are more hands-on. So look at those. And then like there's a program called Steer Emergency Care that I really quite like. I'm not a instructor for it. I've guest lectured on a couple courses. That program, so AEC is a standard, and then it is implemented by a number of different organizations. But austere emergency care is designed for professional responders, people EMT or higher, um, who will be working in an austere environment or remote environment. So that's everything from people on a search and rescue team, ski patrol, offshore medics, certainly like any folks doing like high threat, type medicine. And it's really looking at how do we plan for and treat casualties over a longer period and doing it in a really smart way. And it was created by the folks who created the Prolonged Field Care Collective, and literally wrote the book on prolonged field care, the PFC CPGs. So austere emergency care, you can just search for that. There's a organization that I do teach for, so like disclosure, anyone not ready, they're based in Colorado, in Colorado Springs. Um, I think they're an awesome group. They're cool people. A number of their folks have been over to Ukraine multiple times, doing some really high value teaching. So check them out. They can also do some like custom courses if your organization wants to like bring them in. There's Ragged Edge Solutions that also teaches AEC, and then they will do some private courses as well. So you can do a search for them and see where they're at. We mentioned earlier the College of Remote and Offshore Medicine. I'm definitely a big fan of their stuff. I know they have some online courses and then some in-person ones as well, and they also deliver the AEC program. They're quite good. They're probably one of the most international organizations, training providers that I know of, that they have instructors from South Africa, Australia, Poland, Ireland, the US. So COROM ends up bringing together a lot of different perspectives. And then they do some courses in the EU, and then elsewhere in the world as well. So check them out. Um, so I don't have firsthand experience with the next two, but I know they have a really good reputation. So there's SOA Rescue, SOAR. In particular, they have an extended austere provider course, and then technical austere medical evacuation, or TAME. Those two courses, I think they're both a week long, and both have a little bit different focus. But SOAR has a really good reputation. I've met most of their folks at a few conferences, and both of those courses uh, help set you up to provide patient care in a more austere environment, with the understanding that you are carrying drugs, you're carrying vents, you're doing a higher level of patient care. And then the final one I'll mention, European Medics has just started organizing some training. They have something called the Tactical Clinical Operations course that seems, and I have no financial affiliation, and I haven't taken this course, but it seems very similar to some of the trauma care that I've done in terms of like working in these, military, like role 1, 0.5 type, like forward stabilization point um, areas. And so I think that would be a really useful course because it's a higher level of care than your average like tactical medic course. But it's also not like advanced trauma life support, which is focused on very much a well-resourced in-hospital setting. So I think the TCO program from European Medics is going to be good. And I know they're an organization that has really made an effort to rapidly seek input, especially from people in Ukraine, but from elsewhere, to continually kind of evolve and push their content from social media to the stuff that they release on their Patreon um, to basically just evolve pretty fast because that can be a challenging process for organizations.
And what about like something non-medical? What do you think about heat
Ooh.
training
Yeah, so
or the
heat.
like?
Yeah, so absolutely. So it's good to think about the non-medical training. So heat or hazardous environment awareness training. There's multiple different providers. So heat is a pretty standard term, and then there are multiple training providers that will offer this. Um, some heat courses will be a little bit more focused on either one geographic area or one threat profile, and then other ones will be a little bit more of like a shotgun approach, depending on who the primary clients are. I think a heat course can be really useful. It's going to cover um, a pretty wide range of stuff from like, using a radio, which you're already familiar with, but then also like if you're approaching checkpoint with armed, non-uniformed personnel. How do you deal with that? Because that's a real thing that we encounter not only in conflict environments, but in some semi-unstable, non-conflict places as well. How do you deal with attempted kidnapping or kidnapping? What's your conduct after capture? How do you deal with communications planning? Like you're creating a PACE plan. Most heat courses will cover a little bit of first aid as well, usually like stop the bleed and a little bit more. But even if you already know tourniquets and all that stuff, getting reps in is always good. And then doing it in a stressed environment, doing it with team members who may have a much lower level of medical training. Like I think there's really high value in that. So yeah, I think a heat or a heist course, both of those can be really useful. Do your due diligence at the companies, try to find reviews on them. Even if you are just searching on Reddit and you have a company in name, throw the company name on Reddit and see if anybody's talking about it. Um, uh, if you are a journalist, there are some organizations that do training for journalists. They're going to be going into conflict environments, so kind of look for that. And then, I mean, other non-medical stuff like uh, depending on where you want to work, if you are able to take maybe it's swift water awareness, maybe it's basic rope rescue. Like there are some of these rescue things that even if you are not planning to effect a technical rescue, maybe that is something to get yourself out of trouble or to, self-rescue. Especially if you are really drawn to the natural disasters and that sort of things. Like yeah, you might sort of be, naked and afraid and kind of alone and need to rely on non-medical skills to get yourself out. Um, so yeah, I mean, time and resources depending, take some of those additional classes, especially I guess on the rescue side, if it's training that is designed for low resource environments. So, like on the wildfire, oh, and we didn't even talk about wildfire. There are medical opportunities for employment in the world of wildland firefighting. So people can get hired as fireline EMTs and paramedics. There's also REMS team, remote extraction module support. Is that right? REMS.
I think that's
So there are these other other employment opportunities, but then there are training opportunities, public enrollment training opportunities for wildfire medicine, for REMS teams, that they're looking at how do you do a low angle rescue with a basically a small fanny pack's worth of rope and hardware, right? That is probably going to be more applicable to some of these remote and austere environments than the very traditional like tech rescue, rope rescue 1 and 2, where they say, okay, so we're going to pull the heavy rescue truck up to the building, and then we're going to take out 1,000 pounds worth of carabiners and 10 mil, 12 mil rope and whatever. But the if you're interested, or if you're especially if you're thinking about like urban type stuff, you might look more towards security focused training. Uh, you might even think about like hand tool vehicle extrication as another thing. So yeah, I think, and you make a really good point of looking towards non-medical stuff, um, because we could be the best paramedic flight whatever in the world, but now we are in a radically different environment that has new challenges and new problems, and so we need additional skills. Um, yeah, so really think about kind of rounding out uh, the training you have, and if language is always a cool thing, right? So if you already speak a second language, fantastic. If you are good at languages and want to learn, pick up another language, because it's never bad to be able to talk directly with your patients or your coworkers or whatever. And as Americans, we typically don't speak another language, which is very uncommon in this world.
Um, and what about like all these courses seem super interesting, but what if you don't have any money? Like you can learn languages for free, so we'll leave that one aside. But what about some
Yeah,
ways to do like self-directed learning? Because we all know that like folks working on a truck in a 911 system aren't generally like rolling in cash.
yeah,
What are some ways you could like develop a skill set to get into this space without like shelling out a couple $1,000s for a course?
yeah. So there are groups, so like COROM and I believe the WMS, the Women's Medical Society, will both do some like free presentations and lectures. So hop on those. If you do have any continuing education funds, even if it's like 200 or 300 bucks a year, that might be enough to let you go to a conference, but not a full like 5 day course. Um, Also, the clinical practice guidelines that I mentioned, they are very well written. So you can, go to deployedmedicine.com, set up your free account there, log in, download the prolonged casualty care guidelines, and then start looking through. Maybe start with something like hemorrhage control that you are probably already fairly familiar with, and see what they do that's different. And then, or airway management or whatever. And then start Googling between PubMed, between like Khan Academy. There's some, Larry Mellick is a physician from Georgia who's got a channel on YouTube. Um, there are some great resources where if you are looking at this clinical practice guideline and they're talking about a med or a procedure you're unfamiliar with, you can use that as a springboard to then go find a credible resource and say, okay, so they're talking about maybe it's doing an incision and drainage for an abscess. Okay, so they talk about that in the clinical practice guideline. I'm going to go look on YouTube, on PubMed. Family Practice Notebook is another really good resource. And you're going to start learning about that, and you're going to see what equipment is required for it. What are the indications? What are the contraindications? What are the complications from this? Now, at that point, you are not credentialed to do that procedure, right? But you are starting to understand how these things fit together. And now maybe you do have an opportunity because you work in an ED. Maybe you're an ED tech, something like that. You can say, hey, doc, can I observe the next IND you do? Right. And now you are taking some of that academic stuff that you've kind of gathered on your downtime, and now you're starting to bring it into practice. Um, so I think kind of a hybrid approach there with the clinical practice guidelines being uh, a good starting point, or the Wilderness Medical Society's CPGs as well. That's going to be another really useful tool.
Yeah. Yeah, I agree with like the minor procedures thing. I think that is super useful to have like additional people that can do that kind of stuff. Like,
Yeah.
um, yeah, like even like simple sutures, like pulling a toenail,
Yep.
IND, like that kind of stuff. Like you can pretty quickly like read up on it to understand what's going on, and the next time you see one, like take a more active role in like first observing and then like helping out do one. But I think that kind of stuff is really helpful. The other thing that I found really helpful is like getting more comfortable using ultrasound. So that's something
Oh
that
yeah.
is really useful in like most of these settings is just being able to quickly do, like on the trauma side, knowing how to do a fast exam
Yep.
saves a lot of time because in a lot of these places, it's just the physicians who can do that. But they also have to do, they have to manage the whole patient. So if you can offload that task with like a good degree of certainty that you like know what you're looking for. I think that's super helpful. And then once you know how to
Yeah.
do that, it's pretty easy to scale up. Like if you have access to a machine or someone who like bought one off of eBay, um, you can just, like kind of extend your exam. So like you know how to do it fast. Like next time after that, if the patient's stable, like take a look at their heart. And after that, like try and find the IVC and just like kind of work up
Yeah.
that skill set. I think that's something that, yeah, and the price point's only going to come down on those. Like right now,
Yep.
you can get a butterfly first generation for like around $1,000, 1,200 bucks maybe.
Yep.
Um, and yeah, they just get cheaper and cheaper. So
And ultrasound's non-invasive. So it's something that you can practice on healthy patients. Like the only consumable is the gel and your paper towels, basically, right? So it's something that once you get started, and especially if you are alongside somebody who's more knowledgeable, uh, that is a tool and a skill that you can practice more. And then, I mean, with the ultrasound, like the diagnostics can be super helpful. IV access. Holy crap.
for sure.
If
Yeah, totally.
especially even just from a medical logistics standpoint, the cost of an IO needle, like an easy IO or a Talon, we're talking like $100+ per IO needle, right? Versus pennies for an IV catheter. And if we have somebody who's deep in shock, yeah, it might be great to drill them right away. But if it takes 10 or 15 seconds longer to find a deeper vein with the butterfly or with another ultrasound, and then we throw in that 18 because we've now found a decent vein that was just a lot deeper, holy crap, that is awesome.
Yeah.
So yeah, so like ultrasound guided IV, and then uh, I've had minimal training and I'm not comfortable doing it on a patient, but regional blocks. So being able to use ultrasound to effectively deliver pain management for an entire leg, part of a leg, a foot, a hand, um, that can reduce the amount of your opioid burden. It can reduce a lot of your side effects of the various pain meds we might have to give. So for some, and I know paramedics that are fantastic with regional blocks. There were more and more physicians in Ukraine that were doing regional blocks on a regular basis. Um, so yeah, like that's another awesome tool. And then even in the pre-hospital, like the normal pre-hospital environment, I wish we did that at all or more. Um, you know, your especially like your elderly patient who maybe already kind of has a soft blood pressure and now we're pretty sure broke one or more things. I don't know if I could stop their pain without like giving them fentanyl or morphine, like that'd be cool.
Yeah.
So,
For sure.
yeah, so no, 100% ultrasound is a great tool, and especially if you have a service that's already deploying it in some way, it's really pretty easy to learn more. And there's some great resources online. Um, yeah, and the more patients you scan, the better. Even if you don't have a doctor next to you or a skilled somebody who's really skilled, with all of these digital ultrasounds you can save the image or the video. So if you're scanning somebody at the station and
Mhm.
you're looking for where Morson's pouch would be if they were bleeding, and you're not sure if you're seeing the liver, take that, scan, record that video, and then take it to somebody, maybe it's, grabbing a doc at the hospital and saying, hey, we're doing training at the station. Can you identify what I'm looking at here? Right. Um, and that may be kind of a way to help you get reps in. It also builds rapport with those providers. They're like, oh, the ambulance drivers are learning ultrasound. Whoa, okay, all right.
Yeah,
Maybe they're not ambulance drivers, right? Like maybe they know stuff. Yeah, so when we take an active role in our learning and we express kind of a respect for that knowledge and trying to gain more, that can really help our relationships with our coworkers in other settings.
for sure. Okay, and then I just have one more question for you. Um, what does your process look like for, let's say you've like done all this prep work, you found an opportunity, and now you're like getting ready to go. What are some like considerations when you're looking to go out on maybe your first assignment or maybe just an assignment in general?
Yeah. I mean, if I know somebody on the project or somebody that's worked in the area or worked on a similar type of mission, I'm probably going to reach out to them uh, and ask for some advice. I'll spend a few minutes Googling the country, the conflict, whatever, just trying to get a slightly better understanding of the context of like what was the country like before this thing happened. And then I'm also now starting to think about like what diseases are endemic to the area. Do I need additional vaccines? Um, the CDC's website used to, maybe it still does, had travel recommendations for different places. Like, do you need yellow fever? Do you need uh, do you need
Malaria.
prophylaxis for malaria? Yeah, exactly, right. So all that kind of stuff. Uh, if I know that we're going to be dealing with a particular patient population, I might like either do some like kind of reading in the moment, or I might, if I know I'm going to be dealing with burns, maybe I'm going to download a couple of like burn textbooks or clinical practice guidelines with the intent that maybe those get used at the bedside, or maybe it's on the flight over, the drive over. I'm going to be reviewing some of that stuff. Um, uh, and then just like basic stuff. I mean, have copies of your passport, copies of your driver's license, both, physical copies and digital. Um, consider having a second smartphone that's unlocked so you can put a local SIM in it so you have data and connectivity. If you can afford a Garmin InReach, even a first generation, that's going to give you the ability to text message through the Iridium satellite network. So it gives you a little bit of redundant communication. And then if you're thinking about SATCOMs, make sure you're not going to a country like India where SATCOMs are illegal for civilians. So just kind of be aware of that. Um, yeah. I mean, pack a basic trauma kit, just for yourself. If you're going to a conflict area, plus that trauma kit up a bit. If you can get an EpiPen or, something like that, even if you don't have an anaphylactic reaction yourself, it's not a bad idea to carry. Carry antidiarrheals, get a prescription for Zofran, ondansetron, because sometimes that happens and it's better when you have antiemetics. Um, Yeah, I mean, there's a lot of little stuff like you'll probably overpack for your first couple of trips. That's fine. Like you'll learn it's going to be heavy. Either you'll donate stuff, whatever. Yeah, I mean, I think it gets easier um, with time and experience. Um,
What about a med
yeah,
kit? So I know,
yeah,
I think you and I are pretty similar in that we have like a lot of our own like kits, but
yeah,
normally when you deploy, the assumption is that like whoever you're working for, like they have their medical stock. So you might be asked to like bring things for donation, but are there things that you like to take along?
yeah. So I have I have some basic stuff that yeah, so I'll think about it in two ways. So if I'm just thinking about myself providing like doing patient assessments, like independent of any patient care. I have a diagnostics kit that I put together that's like the size of a maybe a football. It's got a manual blood pressure cuff with detachable cuffs from uh, either an infant or a small child up to a large adult. And then the cuffs just pop off the gauge. It's got my stethoscope, an otoscope. I have some fluorescein dye for fluorescein dye test in the eye. I have the light for that. Um, I have a small glucometer with some test strips, a headlamp with some extra batteries, urinalysis strips. Um, I have a little notepad to write in, and then what's the little like the NP's little spiral bound reference book? Do you know the
Oh,
one I'm talking about?
I think I've seen it
Maxwell. Is
before.
it
Yeah.
Maxwell's?
Don't know the name of it.
Yeah. But
It
so
would
it's a
be
little
like reference
reference.
guide. Yeah.
Yeah, that's got like it's got, cranial nerves, it's got normal pregnancy stuff, it's got basic lab values, it's got like a small two-page basic physical exam with like key findings. So it's a small little reference. I have a Broslow tape that I keep in there, and because I don't like dealing with kids and they're scary when they're sick, and a Broslow tape makes the math a little bit easier. Um, so yeah, that's in the kit. I feel like there's a couple other. I have a pulse ox in there, so like that kit is fairly compact. That will like always go in my day pack. And then if I'm doing like medevac, more critical care stuff, typically I'll add a fanny pack that's going to be on my person. I'll have a really good pulse ox in there. I'll have my Emma Clear Eye Pro, a couple of pairs of nitrile gloves, my stethoscope, pair of trauma shears, and then when I was working in Ukraine, I had an additional tourniquet, a little bit of gauze, and some wound packing and elastic bandages as well, either for the patient or for myself if something happened. Um, and that's in addition to like in my pockets, I'm always going to have a multi-tool, a pen, a flashlight. Usually I have the Corom field guide either in a pocket or in a backpack. I always have a notepad, a Sharpie, a pen, a headlamp on my person in addition to the headlamp that's in my kit. Um, what else? Yeah, but so I'm looking at like the basic diagnostics to be able to collect a set of vital signs, to be able to document those vitals. And then, yeah, and then, the Emma, if we're really thinking about a sicker patient. Um, and then depending, and like, because I've worked in the film world, set medics have to provide their own kit, and then the production company pays the set medic a day rate, and then they rent the medical kit as well from the set medic. So like I have additional stuff. So if I know I'm deploying with a smaller, like lower resource NGO, like I might bring like a small backpack that has like trauma supplies if that's going to be appropriate for my environment. Um, yeah, I might just try to fill in an anticipated gap with some of that personal stuff. And then I think redundancy is good. Like I will usually have a trauma kit in my backpack, a trauma kit or parts of a trauma kit on my person or in my fanny pack. And then maybe something like in my luggage as well, that's, can be restock or can be additional. And I don't know, I'm a slightly paranoid person, so uh yeah, the redundancy is helpful when I'm worried about things. So
Sure. Yeah, and I think that's probably something we could spend all day, you and I talking about is like how we prep our kids for different different environments. But
yeah.
yeah, I was just curious. Um, I think that's all the questions I had for you. I was curious if you had anything else that you think was relevant to mention to folks who are interested in this space, or like pique their interest and now they want to get into it.
I mean, I think maintain a good sense of humor. Uh, this can be a really difficult space to work in for a variety of reasons. Like you go volunteer for somewhere for 2 weeks. It's challenging in good ways, and then you go home and that was your 2 weeks of PTO for the year, right? And now you're right back onto a 24. Um, I mean, there can be a lot of challenges if you make this into a career. Sometimes it can be contract work, and that creates a whole nother level of instability in your life. So just try to maintain a good sense of humor. Be aware of your own, like your burnout, your mental health, all that kind of stuff. Try to take care of yourself. In some of these cases, you will, and maybe it sounds cliche, but you'll see the best and worst of humanity. Um, and that can change you. And I mean, I worked 911 for multiple years. Like I thought I had seen a lot of stuff, um, but the magnitude of some of the things that we deal with, and frankly, the hopelessness of some of the stuff that we deal with, in these deployed settings can weigh really heavy. So kind of take care of yourself, and also recognize that the the more, especially if you tend towards working in a conflict environment, the more you do that, the greater the chances are either that you're going to be hurt, or that people you love are going to be killed or hurt. Um, and that's unfortunately just a fact of life, and it's something that you just need to be cognizant of going into it. And you're not going to be able to save everyone. You're not going to be able to save some of your friends. You're not going to be able to save a lot of your patients, um, because the conditions that created the environment that we're stepping into are so much bigger than any one person. Um, but having said that, we can make things a fraction of a percent better for one person. Maybe we teach somebody, and that has a positive impact down the line. So I don't think it's hopeless or pointless, but I think we kind of need to have really open eyes, and be really honest about the situations that we step into, because some of them are truly, pretty massive, and pretty awful. Also, don't be surprised if your view of the world starts to change pretty radically as you get exposed to other people, cultures, countries, problems. Who I am now is very different than who I was 10 years ago or 15 years ago, I think for the better. Um, but yeah, yeah, so take care of yourself.
Yeah, no, I agree with all that. I think that's a great place to wrap it up.
Cool.
Um, Thanks for coming on,
Thanks for
man.
having me. I
Yeah,
appreciate it. It's good to see you again.